Good afternoon, good evening, ladies and gentlemen. I would kindly ask everybody to be on mute before we start welcoming our guest, Dr. Fatima. We're so glad to have you on board, and today is a very special topic. And to be more honest, we're all going to learn today from Dr. Fatima because we actually do a lot of mistakes, and we sometimes address obesity in a wrong approach, which is something that might impact how we are reacting to this. And that's why today, starting with myself, I'm here to learn, to understand how can we understand what is obesity, how can we look at it from a different perspective, and we work all together because we all have a role on reacting towards such, I could say, condition. But again, I'm here to learn from Dr. Fatima. Allow me to start by a very quick introduction about her. I am one of her fans. I have watched many of her events and many of the talks that she did, and I see something very interesting in what she do. On one side, the full name is Dr. Fatima Cody Stanford. And if I say she is one of the obesity medicine physicians and scientists and educators on the same time, a policymaker at Massachusetts General Hospital and Harvard Medical School as well. But on the other side, she is a national and international sought after expert when it comes to the obesity medicine. We do have a lack when it comes to the obesity medicine, and I believe that Dr. Fatima brings and bridges the intersections between medicine, public health, policymaking, and last but not least, disparities. But I would welcome Dr. Fatima, and please, if you would like to say an introduction or something before we start, I would be honored. The floor is yours.
Absolutely. First of all, it's a delight to be here joining you from Boston, Massachusetts. My goal when I'm working with patients or, discussing this disease of obesity is to do whatever we can to reduce stigma and bias, because that often will get in the way of us making progress, regarding this disease, which I think was, what your introduction alluded to. So, for all of those that are listening to me today, there are a few things that I want us to just do at the outset. And there's a word we're going to eliminate from our vocabulary today. I have to say it because I can't tell you what to eliminate if I don't say it. And the word that we're going to eliminate today is the word obese. Obese is a label and obesity is a disease. And when we call someone obese, we're saying that that's what they're characterized by. They have this disease, but they aren't defined by it. So you would say a person with obesity, right? So they have it, but they aren't characterized by it. I'm a Black woman. That is part of my identity. That is who I am. But if I were a person that has obesity, you wouldn't want to put obese Black woman. You say a Black woman with obesity. So that's one key word I want us to go ahead and just get rid of out of our vocabulary, except I have to say it to get rid of it, okay? The next word I want to get rid of as we're talking about this disease that we call obesity is morbid obesity. It is my absolute pet peeve to hear that. We don't call it morbid COVID-19. We don't call it morbid cancer. We don't call it morbid heart disease, and the list goes on, but we call it morbid obesity, and that reflects a lot of our biases. Yes, obesity can cause death, but so can all of the other things that I just listed for you, but we never use that qualifier in front of those other disease processes. And so I want us to just do those things, those two simple things. There are a lot of other things I'd like for us to do, but those two simple things will set up a different stage. It'll set up a different thought process as we begin to work and entertain this global pandemic that is obesity, the most prevalent chronic disease of our time. So I just want to start with setting those ground rules at the outset.
Thank you very much, Dr. Fatima. It's a pleasure. And I told you from the beginning, I'm here to learn myself, because I believe it's all about what we eat. If we manage to do this right, I think our health in general would be in a much better condition. Allow me to start with something, because you just touched that, and this is very important to everyone, including myself. We now classify obesity as a disease. But I honestly feel that we are wrong. And I would definitely be grateful to you if you could help us understand how we define it on a clinical base, and how could we use the word disease? Does it help fight the perceptions and the stigma of obesity, or we should think in a different way?
Well, I'm going to disagree with you emphatically. So let's learn about why this is a disease. We call it a disease when we have pathophysiology that represents the disease, right? So this is a disease of the brain. And what do I mean by that? So the pathways that control our weight are in our brain. They aren't based upon our willpower. They aren't just based upon eating. And what we tend to conflate is this idea of nutrition and obesity. Now, obesity, can reflect something in nutrition. I think it accounts for about 20 to 25%, depending upon what study you look at, of the whole makeup of us. Or for many of my patients, even those with very severe obesity, their diets are much more healthy than most people that happen to have a lean phenotype. So let's talk about the brain as the most important organ that regulates weight. There are two primary pathways by which the brain may travel to determine one's weight status. Now, there is the POMC pathway. Leptin is a hormone, you guys, that signals from fat cells. Fat cells are called adipocytes. So anything adipose is fat tissue, adipocytes are fat cells. And there's a hormone that stimulates from adipocytes called leptin. When leptin stimulates down one of the pathway, it stimulates a neuron in the brain called the POMC neuron. The POMC neuron is the pro-opiomelanocortin neuron, and it's in the arcuate nucleus of the hypothalamus. When we travel down that pathway, we signal the production of something called BDNF. And BDNF stands for brain-derived neurotropic factors. When we have high levels of brain-derived neurotropic factor, we have lean expression of body weight. Now, I exclusively care for patients with overweight and obesity, so my patients don't signal so well down that pathway of the brain. Indeed, they signal down an alternate pathway. That pathway is called the AGRP pathway, or the agouti-related peptide pathway in the brain. When we signal down that pathway, we inhibit the production of BDNF. When we have low levels of brain-derived neurotropic factor, we express more adipose, okay? So it's about signaling in the brain. Notice I had said nothing yet about nutrition. I said nothing about how much you exercise. I said nothing about how much you sleep, but these things are influenced by some of these things. But I want to say that the number one reason why we see obesity is because of genetic contributions. We know if patients are born to parents that have obesity, there is a 50 to 85% likelihood that they themselves will have the disease regardless of how great they are in terms of their diet quality, their physical activity, their sleep, their stress, etc., because of that heritability. And what we find is that they are signaling down that alternative pathway, that AGRP pathway. And so when we're thinking about targets to treat disease, the most effective treatments affect those pathways of the brain. So it had nothing to do per se with the diet or diet quality. It has a lot to do with how the brain decides to signal regardless of those factors. So that's how we call it a disease. I can't call it a disease if I can't come up with pathophysiology by which to target, but I just was able to give you just a brief microcosm of what this disease is actually regulated by. So much like we don't determine what our body temperature is, we don't determine on our own what our set point for weight is. There are a variety of factors that play a part to determine whether we're high or whether we're low. And what we do is we put this judgment on individuals and we make these assumptions about individuals based upon their size about what they're eating. So I'm going to go just based upon my patients I saw in the office just yesterday here in Boston. I had a patient that came in with very severe obesity. And if we're going to classify this, although I hate BMI because it does not reflect any science, we know that BMI is based on actuarial table data. And what they determined was what the cutoff would be and what your risk for dying is based upon your weight status. But what they didn't do was include diverse bodies. They didn't include individuals that were Black, Hispanic, Native American, for example, Asian American, yet we determined this BMI chart, and we use this chart to say the end all be all of how we look at weight status. And so there's some major flaws with that, right? It's an indirect measure of adiposity. But let's look at this woman that came into me yesterday as a brand new patient to me with severe obesity. And just if you guys want to use the BMI criteria, let me just give you guys a few things there. So a person between the BMI status of 18.5 and 24.9 is considered to have a normal weight status, and someone between 25 and 29.9 is considered to have overweight. We get into these three classes of obesity, which we consider to be mild, moderate, and severe. Mild obesity being classified as a BMI of 30 to 34.9, moderate 35 to 39.9, and then those with severe obesity, a BMI greater than or equal to 40. So a patient came to me yesterday with a BMI of 61 at her initial visit. If you really do a deep dive, not only into what she tells me, what we've been able to capture into what she's eating, she eats extremely healthy. Her brain defends a certain set point for weight. In terms of her sleep, she's been working with her sleep doctor for several years, has been compliant with use of something like a CPAP for over 7 years with no deviations, 99% compliance with the device. So sleep is maximized. If you look at her exercise and the work she does with her trainer, which was transmitted over to me, a very robust exercise regimen, but her brain has decided it wants to be here. Now she wants to be here, maybe, and then I would like her to be here. Maybe the guidelines would say she needs to be way down here, but let's look at what's happening. Her brain has decided to defend that set point. So this is this idea of metabolic adaptation. Once you get to a certain weight, your brain is going to do whatever it can once you're there long enough to defend the set point. Think of your body as a gas tank. Some of us have big gas tanks, some of us medium gas tanks, and some have small gas tanks. I'll look at two American actors to really kind of explain this. We have The Rock, right? And Kevin Hart, right? They like to pair them together in movies because the juxtaposition between the two of them is quite impressive. The Rock is a large individual, you know, not necessarily in terms of adiposity, but just in terms of stature, etc. There's nothing you could do to make him small like a Kevin Hart, who's a very tiny individual. I've met him in person. He has a small gas tank. The Rock has a larger gas tank. The Rock's gas tank, the body's going to do whatever it can to defend that, and Kevin's is going to do whatever it can to defend a small set point. Regardless of what they're doing, it's going to defend that based upon just kind of the cards they were dealt. For this woman, this is what she's at. Now, there are many strategies that I can take to bring her into a healthier weight range, but that 61 for her healthy may be 45. And you might say, well, Dr. Stanford, how is 45 healthy when you just told me that was severe obesity? Because the BMI, remember, is an indirect measure of adiposity. I have to look at the whole person, not just what do they look like, what is their body mass, but what is their health status? Do they have type 2 diabetes? Do they have sleep apnea? Do they have cholesterol problems? Do they have fatty liver disease? Do they have cancers caused by obesity? All of these things. And let's say those things are all in really great shape, then I'm not caring about that number. I care about the whole person. And the key thing here that we do that is really something that bothers me to no end is that we judge the book by its cover. We look at the person that has obesity and we make these assumptions that are belittling, degrading, and villainizing to them without doing that deep dive to find out what's beneath the hood, what's below the skin surface. What are the true contributors to the complexity of this disease process where genetics, development, environment, and behavior play a role in their likelihood of developing this disease? Were they placed on medications that could cause weight gains? I've seen some medications cause up to 280 pounds of weight gain. We use pounds here in the US, as you guys know. Was it caused by a major trauma event that then led to major weight gains and weight shifts? What were the multiple factors that may have led this individual, particularly that patient yesterday, to have a significant shift in her weight status? And what I can tell you is that there was a complex set of things that led her to this weight status. If you look at the family history, multiple generations of seeing a similar pattern transmitted, both genetic and epigenetically, right, from our grandparents, for example, which is why, for example, if you look at Holocaust survivors, their offspring, particularly the grandchildren, are significantly much more likely to have obesity than other groups because of that trauma experienced by the grandparents. You might be like, well, Dr. Stanford, How do you transmit it from the grandchild all the way down, from the grandmother to the grandchild? Well, if a grandmother has a daughter, that daughter is born with all of the eggs that she needs, right, to then produce a child, which means that what the grandmother was doing is influencing what the grandchild has. A lot of people aren't aware of like that major influence across generations. And that's something that we see that we often neglect. So, when I look at this particular patient and the multiple factors, I do feel as though we'll be able to make some major progress with her. But my progress isn't getting her to a number on the scale. My progress isn't getting her to a certain BMI. My progress is changing her whole body as it relates to her health. Yes. And whatever number she gets to, my goal is to get her to the happiest, healthiest weight for her, which I don't know what that is right now. It may be a BMI of 45. It may be 38. I don't know. But I'm not going to drive her to a number that's arbitrary, false, and not based on science or medicine.
Thank you. Thank you, Dr. Fatima. I start to connect a lot of dots because even being a doctor, sometimes you miss a lot of I could say, the things behind the scenes to connect and understand the conditions and the diseases in a more holistic picture. This actually triggered my thinking to the current situation, pandemics, epidemics. And I've always heard and read that we say obesity is a global epidemic. Mm-hmm. Honestly, I look at it from a different perspective, but I would love to hear your explanation on that and how the problem escalated, because we speak about from 1975, these numbers tripled per WHO records. But I would love to hear your opinion on this.
So we have to look at our bodies and the environment in which we live. So let's focus on, we'll start with the diet quality, because that's where you guys want to hyper focus, which is fine. When we look at diet, we talk about, I don't look at number of calories, it doesn't mean anything to me, but I can tell you that the processing of one's diet does, right? So if we look at processed versus unprocessed, and believe it or not, almost everything we do is processed. If you cook, freeze, boil, right? We're processing the food, believe it or not, right? If we make any modifications from how it is in nature. Yeah. But if we look at more ultra processed foods, right, which are things that don't appear anything like they do in nature, and compare them to processed foods, we've seen a major shift in that. And we do know that the brain prefers unprocessed or minimally processed food. So if we look at it from a diet perspective, that's one key thing. Now, we think that, physical activity, we presume that physical activity levels are significantly lower. Actually, we saw during the COVID-19 pandemic around the world that actually physical activity levels went up. So people are trying to figure out, well, why did weight go up? Well, because stress went up. Universally, regardless if you're based in the UK or if you're based in the US, or if you're based in Australia, if you're based in the continent of Africa, in Sierra Leone, Ghana, Nigeria, wherever you are, one thing that we can say is that stress went up. When stress goes up in the body, what happens to fat tissue? The body likes to store fat. The body thinks that there is a famine that's coming whenever there's a stressor coming, because from an evolutionary perspective, usually when we experience stress, it was the stress of something bad coming, a famine that we needed to protect body weight in order to get through it. The difference now is that there's usually not a famine coming. The stressor is something like a global pandemic on top of a pandemic, right? That's the COVID-19 pandemic on top of the, let's say, obesity pandemic. We couldn't predict, we still don't know. There's a lot of uncertainty still. It's like, what is the next step? Will there be another one coming behind it? Uncertainty leads to stress, stress leads to storage of fat. We know obesity is a chronic inflammatory condition. Let's look at sleep quality and how that changed. Growing up here, I was born in the 70s, believe it or not. So I just look young. I hope you guys agree with this, but when I was born in the 70s and raised here in the US, when it would get late at night and you wanted to turn on the television, you were met with different colored lines, just a blue line, a red line, a green line. And you just knew that, oops, I think it's time to go to sleep because there's nothing left on TV. If you were to turn on the TV, I presume there in the UK, here in the US, anywhere at any time of night, day, or whatever, I can watch TV, right? Because there's going to be something on, because we have the demand of being able to get whatever we want, whenever we want it. And even if you don't have, let's say, cable TV, we happen to have these things called Netflix, Hulu, et cetera. That means that we can get it whatever we need, whenever we want it. We've become pretty on demand. That's been a major shift. Globalization has actually led to obesity. You might be like, well, Dr. Stanford, that's really mean. Well, let's look at it. I can be rewarded for giving a lecture to my colleagues over in Australia, which might be in the middle of the night for me, which is when I really should be asleep. Now they're waking up. Now my colleagues here at Harvard say, oh, look, Dr. Stanford did a talk to the Australians at 2 in the morning. I'm encouraged, I'm elevated. Oh, she's a good job. She's a good citizen. That globalization is not normal. We're supposed to be, kind of aligning with our circadian rhythm. We're supposed to be awake when it's bright here. We're going to sleep when it's dark, but we've been able to not do that. We have our ability to work with our colleagues at all given times of night, day, morning. That's a shift. You couldn't do that back in the 70s and 80s. There was no way to do that. So all of these factors, this obesogenic environment doesn't interact well with our constructive milieu of who we are as humans. The rapid change that we've seen in terms of stress and sleep and circadian rhythm and all of these things, because of all of the things that I've mentioned, have shifted us into a very different world in terms of how our bodies connect with the world. They aren't it's not as natural. Everything is forced, everything's on demand, everything is at our fingertips at any given time, whether it's looking at a screen. You couldn't turn on, there was no laptop when I was born. You couldn't just turn on your laptop. There's huge computers, room-sized computers, and then they became smaller and smaller. Now you can have them, and now you can open them at all given times and disrupt your circadian rhythm, and then cause your body to not know if it's supposed to be awake or sleep, whatever it's supposed to be doing. It doesn't know, it's confused. So we've deviated globally from all of the things that I just mentioned since the 70s until now, right? And it only continues to intensify as our on-demand society says, I need something, I need it now, wherever it is, whether it's my screen, whether it's my exercise. I can go exercise. I can go get on the Peloton, right? At 2 in the morning. There's a live class going on at that moment if I want to. And for some people that are night shift workers, let's look at our doctors. We can't tell babies to be born at exactly 10:23 a.m. Eastern time. That'd be great, but that's not how things work. So some of our professions even defend, if you look at night shift workers, on average, they have higher body habits. So people presume, those night shift workers, they eat horribly. But if you really do a deep dive, quality of their food is not any different, but they are deviating from what the body's supposed to be doing, which is to be awake when it's bright, sleep when it's dark. When you do deviate from that, the body dysregulates those same pathways we just talked about. So I think you can get a sense of like the complexity of what's happened over this time. Yes, food has changed, but so has sleep patterns, so has activity patterns in the context of this. Our globalization has happened. All of these things have led to this major shift and weight status over time. But we have been trying to hone in on one piece of the pie. And the piece of the pie we've been looking at in obesity is just the food piece of the pie. It's a whole pie. But when we hone in just one thing and it's caused by 100 things, we're not going to make any progress. So the rates continue to go up, continue to go up, continue to go up, because we're only looking at one target. We're treating obesity as if it's the tobacco epidemic. Stop tobacco use, we solve, reduce cancer, things. This is not that simple. I wish it were that simple. My job would be significantly easier. I could just come in and ask my patients, hey, what did you eat? Oh, bad. Let me fix that. It's not that simple. And most of the patients that actually see us in obesity medicine around the world are those patients that, look, doc, I've done this and this and this and this and this, and they've done so many things and their bodies are like, nope, it's not working. And so then they come to someone like me to find additional therapies that may help them change how their brain sees weight. And I think that's extremely important. Even as I think about my pediatric patients that I work with, since my patients range from 2 to 90, when I might start them on a medication or something, and they realize, I had a 12-year-old come into me just last week, and it was like, I'd started him on a therapy, and he recognized that how his cravings, desires, all of these things changed dramatically. And he's like, Dr. Stanford, you fixed my brain. I was like, I did. And that was the important key. He made that connection at 12 years old that, wait a minute, this isn't like me. This is how my brain isn't quite regulating right. And yes, I used a tool to help regulate his brain. And he's like, wow, is this what it's supposed to feel like? I didn't know that. So that's really important.
Thank you, Dr. Fatima. You've covered my next question in a very nice way that pushed me now to take you to the child obesity, because it is a growing I could say, threat. And if we look at it, we do not understand really as general public the impact on health when you become an adult. But I would love to see how you see this, and how would you tell our audience and even the people who will listen to the recording of this webinar, how child obesity could impact health in the future.
Well, what we do know is that if a child has obesity, there is a high likelihood, unfortunately, that that will carry into adulthood. That obesity, of course, is the precursor to almost all the chronic diseases that we live with today, right? Which affect all the organ systems. It could be heart disease, it could be type 2 diabetes, it could be sleep apnea, it could be arthritis, it could be kidney disease, all of, really just a myriad of diseases. And so the earlier the onset, the faster the progression, right? I have patients that I'm diagnosing at 8 or 9 or 10 with type 2 diabetes secondary to their obesity. When you do a deeper dive, because a lot of times, particularly people that are only pediatricians, I'm a pediatrician and an internal medicine doctor, they only focus on the child. So they go and they focus on the child needs to do this, and the child needs to do this, and the child needs to do this. But the child is a child. I think that's key in the setting of their parents, their grandparents, et cetera. So I find it much more effective, and the studies show that if I'm working with all of those generations, and there are some families where I'm working with 3 generations or even 4 generations, where I'm working with the child, the parent, the grandparents, and the great grandparents, because we talked about that high transmissibility of this disease. Now, the strategies I may be using with each of those individuals within that generational cohort may differ based upon what they need, but I'm having to recognize that that child is part of their environment. I want us to think of it this way. Let's say you have 2 tall parents. Let's say you have a parent that's Shaquille O'Neal. I'm sure you guys know him as a basketball player. And then you have Elisa Leslie. She's a basketball player. And you put those two tall parents, the likelihood that they'll have a very, very short kid is low, right? Probably pretty low. I mean, they could potentially have a short kid, but probably not. Probably they're going to have a tall kid because they're tall parents. Much like this, as the obesity rates have risen, here in the United States, 50% of all pregnancies are unplanned. We're going into pregnancy with a higher likelihood of having obesity if we're getting these contributions for the parents. So the kid had a certain set of cards dealt. They were born to parents that had obesity. They come and you can recognize their body habit is already hitting a high curve at the age of 2. So now maybe their parent starts to develop obesity at the age of 10. But each generation, it gets a little bit sooner, okay, unfortunately, and it predates whatever the parent had or whatever the grandparent had. And so here we are starting at the earliest part of life with a child who already has this disease. So then I'm challenged as the doc to figure out, okay, what can I do to help this patient? First of all, let me do some genetic analysis. And you often pick up variants that unfortunately we don't yet have medications or surgical interventions to treat. We are able to test that very easily here in the US. There's a test that we're able to send off that's with basically a minimal, very, very minimal cost or to zero cost to pick that up. But then I have to figure out, okay, what am I going to do about it? How can I fix the brain? It goes back to the brain. And so I might have to use more aggressive therapies earlier on to help prevent the onset of all of those other diseases caused by the obesity. But it's very interesting to watch the kids and watch how they are truly a product of their parents. For example, there's one family that I take care of, where I've been taking care of the father for many years. He's now in his late 40s, maybe going to his early 50s. And I had been invited over to their house to, for a Christmas dinner or something of this sort. And they had their oldest child giving tours, or I think she was just choosing to give tours. She was 6 years old at the time. And it was interesting because when the 6-year-old would take me around this pretty large home, she would tell me the quickest way to get back to the kitchen from that room. I never asked her what was the quickest way, but something in her brain told me she needed to tell me the quickest way to get to the kitchen from that room. That's how her brain was wired. Now, if you talk to her father, my patient, and listen to his childhood around his weight and weight status, there was a similar wiring in terms of how their brains think. And it was that wiring that I saw within the 6-year-old daughter pretty early. She's 6 years old. The parents, it took them some time to recognize what I was seeing immediately. And so now she's also within my care, along with her father, who we've been able to manage. But what brings him the most pain is that he did this to his daughter, meaning his genetic contribution was what led her to be this way. And he recognizes all the stress, the strain, the heartache that he faced as a child with obesity and doesn't want the same for his daughter. And so is trying to act sooner than later. So she doesn't go through a whole life of dealing with the issues that he dealt with. This is how childhood obesity presents. It's complex. Often the parents feel blamed because they've already blamed themselves for their disease anyway. But instead of them feeling blamed, say, look, we can't change it. The cards are already dealt. This is what we have. How do we interact with your child, with you, with your parents, to make sure that we can improve your weight status? Now, what can we do? Because we can't send the child back, right? They're already here. So what are we going to do to optimize them now that they're here?
Yeah, I think you're absolutely right. We need to change the way we think about it. Mm-hmm. And this brings me to the misconceptions.
Right.
If you are to say something to us about the misconceptions, because there are many common misconceptions about obesity, and I would love to hear your opinion on that.
Absolutely. Well, I think there's like so many. I think we would like keep the whole, we would take up the whole time of the rest of the webinar, but let's just go with a few things. We assume that patients with obesity are, yeah, let's go. I'll start with the first one. I think we assume that people with obesity eat horribly, right? We make this assumption that, oh, if they just ate better, they'd be fine. They just really need to just push away from the table. They just need to reduce the calories. That would be number one. Oh, you know what? Number two, they just need to exercise more because they must not be exercising. The assumption is they don't exercise. They don't really care. They're lazy. They're slothful. You know what? They don't exercise. That's number two. Number three, they obviously have never tried. They look at this person. They're walking down the street. They let themselves go. This is horrible. This is despicable. They haven't done enough for themselves, right? Number four, there's, maybe they've, tried and failed and that was their fault. It's something they did wrong. Instead of recognizing that there's metabolic adaptation where the brain is going to work to defend its set point to its original set point. And when you try to deviate from that, let's say they carried 100 pounds in excess, they lose 50 pounds. If they're unable to maintain whatever that is, the body's going to defend that even higher set point because it's very angry with you. It's like, what did you just do to me? Don't do that again. I'm going to do whatever I can to bring it back. And I would say another misconception is that it's not a disease, that this is just like, all about calories in and calories out. And, that it's really that simple. Unfortunately, we are not like just simple vessels. We are all unique. Every single person that's here today, every single person that will come back and look at this later, we are all unique and we're different. Yes, we are all part of the human race, but that's where the individuality, that's where, our kind of similarities stop. We individually are all different. Now, if you have identical twins sitting here today, maybe there's a lot of similarity there, right? And we presume I can take you and put one twin over in China and put one twin over in Brazil. And believe it or not, regardless of their upbringing, et cetera, we actually see very similar weight status with those two when separated. So what does that tell us? It's not just what they're eating. It's not just what they're drinking. You separate them at birth, they come back and they meet at the age of 30 and they're like, oh my gosh, they look just like me. And wait a minute, their body is shaped the same way. That genetic piece, hugely important, right? So I think those are some of the key misconceptions, I would say.
Thank you. Thank you very much, Dr. Fatima. I will take you from the misconception to the conflicting information, because this is one of the things that people are facing. And nowadays, the open world, we have social media, we have WhatsApp, we have everything. And then today they hear, eat this, it's healthy. Tomorrow, no, it's not. This is too much. This is too little. And many people knows too little to be dangerous about it. And hearing from you something about that would definitely help a lot of us, including myself.
Yeah, I think, obviously a lot of us spend quite a bit of time on social media. It's where we consume a lot of our information. It's quick, it's on demand, it's fast moving. You don't have, you can hop on, hop off and still feel like you're in the midst of things. Except, I feel like social media often, and the media as a whole, not just social media, but global, media, whether it's print or television, media as a whole, I'm going to throw just media into this, paints these ideas of what's idealistic. We paint the ideas that idealistic is only someone that looks a certain way, right? Aesthetically, a certain size, et cetera. But what's interesting about that is that we never question individuals that are lean about how they ended up that way. Maybe they used really deleterious techniques to get there. Maybe they had a history of drug abuse. And because of their drug abuse, they are very, very lean. And so nobody asked them like, oh, wait a minute, how did that happen? We just acknowledge, oh, wow, look at how lean you look. Well, that's really great. Not recognizing that this was a product of something really, really harmful to their health. I think that that's something that we see. And then we see people that post, I lost weight the natural way, which means they say that they lost weight, I guess, by just eating less and exercising more. And so that because I did this, you should be able to do this. And if you don't do it this way, then you're really like a bad human. And so what that ends up happening is that you have people, we have therapies that are evidence-based, that are published, medications, surgeries that are really effective. Lots of strong evidence showing their ability to really have major change on individuals, but the people that need them are scared to seek them. The people that need them are scared to seek them. Why are they scared to seek them? Because it's not the natural way. I need to do this, I need to do something harder. I had a patient come into me about 3 or 4 weeks ago. And what was confusing to me is this patient came into me initially as a new patient about a year ago. And every visit, her weight kept going up. And I was like, well, this is weird because, gosh, I must be doing something wrong, right? So I immediately turned to myself, well, what am I doing wrong? Like the medicines that I wanted to prescribe, obviously they must not be working for her. And that happens. So I asked her, I said, well, I'm really concerned because I feel like we're not making any progress. Every visit I see an incline, in your weight, I'm not doing something well enough. And so I said, so how is the medication not working? What are you feeling when you take it? Oh, she's like, oh no, Dr. Stanford, I never took the medicine. And I said, okay, well, it took us a lot to get that medicine. What happened? Why didn't you take the medicine? She was like, well, I don't feel like I deserve the medicine. I said, okay, well, so I wrote the medicine. We did a lot of work to get it approved. So the medicine should be there, but you don't deserve it. Why don't you deserve the medicine? She said, well, I'm not doing 20,000 steps of walking at least every day. I said, where did you get the idea that you need to do 20,000 steps a day? She said, oh, no, I decided that. I'm only doing 15,000 steps a day on average. And so until I get to 20,000, I don't deserve to use medication. She's been taught that she needs to do more and more and more and more of something. And even though she's 63 years old and has had that pill for 63 years, she still needs to do more of that to deserve the medicine that I've prescribed that I thought was just not effective for her, because every medicine doesn't work for every person, right? Like I said, we're all unique. But she has decided to punish herself, to be punitive to herself, because that's what we as a society do to people with obesity. We punish them, and in turn, they often punish themselves. Let's not use these tools that are here, that we worked really hard to get for you, that have been proven to be effective in most individuals, because she decided in her mind that she needed to walk 20,000 steps a day on average. And until she gets there, she's not good enough. She's not worthy. And that's what we've taught them. What's what we taught them? That's what society, that's what the media teaches them, that they're not deserving. And it's unfortunate.
It is unfortunate. I think we need to do a lot of work at the media side. It has to be a little bit evidence-based regulated, because we put the people in the middle of water, in the middle of the sea, and they don't know how to swim.
Right.
And listening to you carefully, Fatima, emphasize something that I always believed in, that every human being is different. There is no guidelines.
No.
I'm one of the people who is against guidelines, and CPGs has been part of all what we do in medicine all over the planet. But The stories you're mentioning confirms my belief that you treat every single patient as an individual case, as an individual needs, where we need to hear, listen, understand, and tailor and individualized solutions and plans for this person. But I would ask a question that a little bit might seem that it is contradicting, but it's a general knowledge.
Okay.
From the treatment options, what are the common treatment options for obesity?
Absolutely.
Medications, the surgery.
Yeah. So, I mean, obviously the cornerstone of all of our treatment strategies is lifestyle modifications, right? You know, we want to optimize lifestyle. We want to look at nutrition. We want lean proteins, whole grains, fruits, vegetables, right? To be the cornerstone of meals, not a hyper focus on like, I have to have this number of macros and all of these things that stress people out, which we taught stress causes storage of fat, right? So why stress people out with how they're eating? You know, we want to have the lifestyle, you know, we want a baseline of, you know, certain level of physical activity, 150 minutes of moderate intensity activity per week. What is moderate? You could talk during the activity, but not sing unless you're like Beyonce or somebody like that. You know, we want good sleep quality. Those are types of things that we're looking at, you know, and stress reduction, right? Those are kind of the lifestyle pieces of puzzle. Some people will have some behavioral components that really we need to focus on. And by behavioral components, maybe they have a history of really significant cravings and desires. Maybe they have night-related eating disorder, which means you don't have any idea that you ate, but then you wake up and there's Oreo crumbs in your bed. These are types of things that we would work with a psychologist, psychiatrist on to make sure that those things are under wrap, because we can't really make progress in progressing to our other 3 steps without really making sure those things are in play. Another thing that we would consider are medications. Most of the medications that we utilize that are approved here in the US and many around the world actually work on different parts of the brain. A lot of people think that they're just appetite suppressants. They're not really just appetite suppressants. They're literally targeting a part of the brain that tells your body to, you know, store less and burn more. And so it works in different ways in your brain. So phentermine, for example, which is the first drug approved here in the US back in 1959, it inhibits something called norepinephrine in your hypothalamus, okay? That's how that works. When we talk about our GLP-1 agonists, which are kind of like the new kids on the block, the things that everybody care about, they stimulate that POMC pathway, going back to the beginning, that pathway that tells you to eat less and store less. So you talk to people on this, they're like, oh my gosh, I never knew this is what people feel like. Like, this is what you feel like all the time. I never knew that this feeling existed. Topiramate is another drug people might use. It stimulates something called gamma aminobutyric acid in the brain. So here we keep going. All of these things work in different ways, typically on the brain. We have devices that can be utilized. Devices kind of have a variable response and variable evidence. There's some devices that are like pills, kind of a hydrogel-based pill, for example, that expends in the abdomen. You have things like balloons and things of that sort. And then what is by far still to date the best treatment for moderate to severe obesity in both children and adults is metabolic and bariatric surgery. The most common surgery performed all around the world is the sleeve hysterectomy. A lot of people think it works by just making the stomach smaller. And yes, the stomach is smaller, but what people fail to recognize is that ghrelin, which is a hormone housed in the part of the stomach we take away, stimulates hunger. And so when I remove where that's being stimulated from, you're like, wait a minute, I feel great. So then people say to me, well, then Dr. Stanford, why do those people regain their weight? What did they do wrong? What you don't recognize that ghrelin is also in the brain, and we didn't do brain surgery, we did stomach, kind of GI surgery, right? So what happens is we've taken away one part of it, and what happens is there's an upregulation in ghrelin in the brain over time. So over time, all of a sudden that hunger starts to creep in. GLP-1 levels, we have GLP-1 in our body. When they're high, we eat less, we store less. They go pretty high after surgery, but the further we get out from surgery, they start to decrease. And so over time, we have to recognize that it's a tool, but it is a tool in this chronic treatment of this disease. And it does not immediately fix everything. It's kind of a honeymoon period, right? That first 6 months to a year where people are losing, we're seeing resolution of a lot of diseases, but we have to stay on it. And for many patients, they will require additional therapies to support them post-surgery. Many of them will, I would say more than 90% of my patients are also on medications post-surgery to help complement the treatment of this chronic disease. So those are the therapies that are available all around the world.
Thank you very much, Dr. Fatima. I think that was pretty unique, comprehensive, disruptive, but I've learned a lot, and I trust that our audience as well. In order to move to the next phase and start with the questions and answers, allow me to start with some of the questions that I see on the chat. Many people have been very much interested with what you're saying, and I could see a lot of questions until now. On the other side, please, for the participants, feel free to raise your hands. So after we finish the questions on the chat, we'll move to the participants and answer the questions. I'll start with the first question, and it's coming from Islam El-Nabrisi. He's saying, amazing explanation. Rarely we would hear something like this, but scary at the same time. Saying that all what we do is worthless, as our genetics and epigenetics over control the whole thing. Over to you, Dr.
I would say don't be scared. So I think being knowledgeable about the fact that that is such a major contributor, it means that we can take action sooner, right? So if we know that these are major contributors, we know, certain things are within a family, we can take action sooner. So bring that 2-year-old in to see me. Don't wait until you're 40 to see me, or 50 or 60, or even I have new patients that enter in at 82 years old. I'd love to see my 82-year-olds. You guys still come in to see me if you guys are listening, but I would like to see you before we get there. It'd be nice for me to make a progress so that your quality of life, your health related quality of life, your disease processes, that we can change those sooner. We can have an influence in those sooner, so that you don't have to live with diabetes for 40 years, that you don't have to live with high cholesterol for 50 years. You don't have to have multiple heart attacks. I don't want you to get to that point. I want to prevent those things. And so if we know these things about our families, for example, let's take action sooner than later. And I think that what we find, actually, I don't think, I've published on this many times, is that if we intervene within kids, their outcomes are so much better than waiting until later, even middle or later adulthood. And so I think that, I would say I'm empowered. I would feel empowered with that knowledge to begin to take early action. And I think that early action has huge implications for that child, not only in terms of their health, but their job prospects, their ability to achieve and sustain in life, because we know of the biases that come with having this disease that is obesity. So I would say use it as a tool to say, hey, you know what? I see this is what's going on in this family. Let's take quick action. Let's get to that kid at 2, and let's begin to make some major shifts.
Thank you, Dr. Fatima. Moving to the second question, and it comes from Professor Fatma Al-Anouti. She's saying, thank you, Dr. Fatima, for the insightful talk. What is your opinion about the new trend of metabolically health obese phenotype? Is this really valid in clinical settings?
Yeah, I don't like that terminology because it has the term obese, right, which we eliminated. So I don't like that. I would say, and of course, we're still using the BMI criteria. The BMI criteria is what we're still using, and I do think we need to modify that. And I'm going to work on that, you guys, if nothing else. I think that we do have different body types and different health at different body types. You may have someone that's lean, that's very unhealthy. When you do a beneath the surface, they have really horrible cholesterol. They have high blood pressure. They have all these things, but we look beneath the surface and you're like, oh, but their weight status is nice and normal or healthy, whatever that means. And then you have someone, like I said, like my patient the other day, who loses a certain amount, and then they get down to still very, have a high weight status, but they're healthy. So I don't like the term metabolically healthy obesity, but I do think that you can have different health status regardless of your size. So I think that's the question, more of the question you're answering. And I do agree that people of larger size can be healthy. It's just that we have to do a dive beneath the skin surface and not just judge them by how they present, and see how healthy they actually are.
Thank you. Augustine is asking, does climate change contribute to obesity?
Absolutely. And actually, there was a large paper that came out of the Lancet about 2 or 3 years ago talking about the syndemic of obesity and climate change. One of the key authors was a gentleman by the name of Bill Dietz, D-I-E-T-Z. It's a really comprehensive paper that looks at climate change and obesity. in really great detail. I would take a look at that paper. I'm not an author on that piece, but I do think it's a great paper, and I've quoted it in different lectures before. So I do agree that climate change is one of the many contributors to the rise in obesity rates in the world.
Thank you. A question from Quake. He's saying, is there a clinical way to evaluate when a reset has taken place? Or is the set point unmodifiable? It's a technical.
No, it's modifiable, right? We modify it. I mean, like for a very small percentage of the population, about 5%, kind of lifestyle factors will significantly modify, the set point. But for most, there will need more advanced therapies. And so medications or surgery can modify the set point. Now, medications only modify the set point when you're taking them. So what people have to recognize that if they find medications that work for them for their disease, that is obesity, much like treating hypertension or diabetes, they work only as long as you use them. As soon as you pull them away, we're no longer working on that set point, right? Surgery has a more permanent shift on average, right, of changing set point. But like I even told you, over time, the body wants to try to move back into its norm. And so, for unfortunately, like a minority of the population, like I said, with lifestyle, will be able to majorly shift their set point. It's not anything specifically you can look for clinically other than looking for weight stability. I would say that's the key thing. And only person you want to compare that person to is to themselves. So I never pull up my patient's graph and pull up another patient. I pull up them to compare it to them. So my last patient yesterday was a patient that I started seeing back in 2000. It's now 2022. And I compare her to her across that 22 years. And so if I see points of stability, 5, 6, 7 years, 8, 9 years, I have done something to set her in a different set point. I hope that's helpful as you're thinking about it clinically.
Thank you very much. Another question from Quake is saying, is there any assessment tool that assesses when natural ways as first-line therapy can be confirmed as futile?
No, I would say the answer to that is no. There's not really I would say it takes a little bit of, my initial appointment for each patient is a little over an hour. So I'm trying to get at every single thing to get an understanding of all the potential factors that may have contributed to where they are. And since it's not one key thing, usually it's multiple. Very rarely am I just getting that one thing. Ooh, that one thing is like your sleep got disrupted. And so that disruption in sleep led to weight shifts. That's rare. That's a rare person that you just find one perturbation, right? One shift that led to them. So I would say that there's no clear way of doing that. Quake, I think that you have to really get intimately involved in the whole person and look at all of those different nuances.
Thank you very much. The second question is coming from Elon Gava, and he's saying, great to see you. And thank you for bringing this amazing speaker. And that's not a question, that's a compliment, Elon.
Thank you. I like it. I'll take it.
And I think Elon is also connecting from Chicago, not very far.
I'll be there in a few weeks. Come find me at the AMA meeting.
I actually didn't read a lot of compliments. I have another compliment from Keith St. John, who's saying Dr. Stanford is dynamic and knowledgeable speaker on this important topic. Thank you for being here and for arranging this. And another compliment from Shiam saying, thank you very much. Her question is, what can we do? What can we go deep inside the possibility of reversing diabetes type 1 by treatment of obesity and following a fat restriction diet?
Yeah, that's interesting. So, type 1 diabetes obviously has a huge autoimmune component as opposed to type 2, right? So, we're looking at a different cohort. When we're looking at type 2 diabetes, where we know that obesity is a major contributor, actually, if you look at worldwide numbers, about 80% of people with diabetes also have obesity. So it's this idea or concept of diabesity in the type 2 arena. What we're finding, however, is that we have quite a few more individuals with type 1 obesity type 1 diabetes, that are also developing obesity. So what I find is very effective, not necessarily a fat restriction diet, because restriction sounds punitive to people, right? Like they're like, they may be able to do it for a short period of time, but they have a hard time sustaining it. And whatever I do with the patient, I want to sustain for the rest of their life, right? So what can I do for them that sustain them? I'm finding that the GLP-1 agonists are actually, for many of them, actually pretty helpful in terms of helping to augment their response, their weight response. There are several papers, I've not written any of these, this is not my area of research, but there's several papers that do confirm this. And I individually can tell you with several of my patients that do still have just slight ability for their pancreas to do some work, some great response in those patients with type 1 diabetes. So I would be I would yield more towards pharmacotherapy approaches, not because I don't believe that dietary approaches don't work, but the only dietary approaches that work are the ones that people will sustain forever. And I just feel like a lot of people will take on a keto diet or take on this diet, and they'll do it for a short period of time, and it's effective for whatever the short period of time they're using it. And as soon as they stop, what happens is their weight goes up even more than where they started. And that causes that weight cycling that we see over time. So that's my response to that. Hopefully that's helpful for you.
Thank you. It is very helpful. Another question coming from Lena. She's saying, if you want to check obesity for an adult or a child, how to do the approach, and from where to start?
For a child, for the obesity
or an adult. The question is
an adult. Oh, okay. I'm sorry. So the way that we look at it worldwide right now is for children, we use growth charts. So growth charts go from the age of 2 to the age of 20. And we look at the growth chart, which is very different than what we do for adults. We look at BMI percentiles. If you're below the 5th percentile, you're considered to have underweight. If you're between the 5th and 85th on the growth chart, you're considered to have a healthy weight. So a pretty broad range of healthy weight. When we get from the 85th to the 95th, we're considered to have overweight if we're a child, and anything over the 95th percentile is considered to be a child that has obesity. Now, there are 3 classes, just like we talked about in adults. The difference here is that we're looking at percentiles, and we're looking at what we call an extended BMI chart for children that have obesity. So if you're between the 95th and the 120th percentile, you're considered to have class 1 or mild obesity. If you're between the 120th and 140th percentile, you're considered to have moderate obesity. If you have greater than the 140th percentile, you're considered to have severe obesity. So that's a lot of numbers to remember. And so it's really confusing to parents, because what they try to do is look at that number that they remembered for themselves and try to extrapolate that. And we don't do that for kids until they get around the age of 20 is when we really start to plot them out. Now, I say that, and I'm going to say something that kind of contradicts that. When we're looking at bariatric surgery, which we do utilize in children throughout the world, we do use adult cutoffs, because the severity of the disease is usually that intense that they are meeting and actually have weights that may supersede what we're seeing for adult patients. So the criteria for qualification to move forward with something like bariatric surgery for those with severe obesity are the exact same standards that we use for adults, which would be a person with a BMI greater than or equal to 40, meaning they have severe obesity with or without any obesity related disease, or a patient with a BMI of 35 to 39.9 with some of the key obesity related diseases like type 2 diabetes, sleep apnea, heart disease, for example. So I know it's a hard question because there's a lot of different moving parts. I told you I'm not a huge fan of BMI. I think that we have to pay attention to things like adiposity, particularly where we're carrying fat. If we're carrying it centrally around our midsection. And men always are like, oh, I wear a size 38 pants. That's not where I'm talking, you gentlemen. We have to measure with the tape measure at the belly button. That's not where you wear your pants. And so you tell me you have a 38 pants and I measure your waist and it's 52 inches, then that's very different. Okay, so we do have target waist circumferences. Where we carry that weight is much more important than the actual number on the scale. So if we're carrying it all in that midsection, it's around all those organs, our liver, our heart, our lungs, all the stuff that's really giving us life. So if you're carrying it more in the hip, buttock, and thigh region, that's not so bad. You know, it's not around any vital organs. It's around bone, tissue, and muscle. So that's extremely important. Hopefully that's helpful. I know it's a lot in that answer because it's not a straightforward one.
That's a very, very informative answer, actually. I have some compliments. Thank you so much, Dr. Cody, for this impactful talk. This is so impactful in my understanding. From Quake Pletcher, Fatima is saying that she could listen to you for hours. Very interesting.
That's very sweet.
And Monique is saying, fantastic session. Thank you very much. And so informative and eye-opening. And we have from Islam a request. He's saying if we could do another session mainly on obesity management, will be great. That's very interesting. I think I'm done with all the chats. Mainly, there are no questions here. Anyone would like to ask a question, please feel free to raise your hand.
I have another meeting I have to start right now, so I won't be able to answer anymore.
Then I think this is...
Yeah, I want to send, first of all, I want to thank you guys so much for having me. It's a delight to be here. Hopefully, you know, leaving here, you leave with a different understanding. I will say that there is a lecture that I would have you watch if you want like a really deep dive on how I think about it. I want to see the pictures. I'm a visual learner. I didn't show any pictures today because it was more of a conversation. But if you, I'm going to put the link in the chat to that particular talk. It's called Obesity. It's more complex than you think. And I think that this will really give you a really great understanding about the complexity of the disease that is obesity. So I told you I'm going to put that link in the chat for you guys to have right now. Feel free to follow me on social media.
That's something we want to do as well. If you allow us, we will share the links on your social media with the participants.
Yes. Absolutely. And I put the link in the chat. You guys will see it posted. That's a full hour and 11-minute session with me talking with slides and things of that sort. So I think and then I have pictures, right, and things of that sort that help you understand those pathways that we talked about. I would say the key thing for any of you here, whether you're a physician or other healthcare provider, whether you're just a person that has obesity or whether you're a family member of someone that does, is to make sure that they feel loved, make sure they feel appreciated, make sure they feel valued, make sure that they know that you are going to work, hopefully now, to help them live the healthiest, happiest life for them without judgment. I think that's the key thing that I want to leave you guys with.
Thank you very much, Dr. Fatima. Actually, I would say after this, thanks to you and to the ladies and gentlemen attending today, and I would take you to what we're trying to achieve over the last 2 years now. Our people, our planet, our health. We always believe that together we can. And that's why I emphasize on what you said. It's our role. I don't have to be having obesity, but I could help others by being really an impactful member of the community. This is the time that we take an action. This is the time that we change. This is the time that we work to create resilience and build a healthier future. And always, we need to remember, together we can. Thank you, Dr. Fatima, and thanks everyone for being on this wonderful webinar, and looking forward to see you next month. Have a great time. Thank you.
Bye-bye. Thank you so much.
Bye.
Bye-bye.